6:36. Thanks, Jordan. At 6:36, the meeting of the Health and Environment Committee is called to order. We do not currently have a quorum present. Present is Heather Jason, Jordan Scherer, Laquita Henry, and
You might have something.
we might have one in a second. Okay, and we'll turn it back. So we still don't have a floor present on Zoom. Is co-chair Cameron Clark. Liz Eastman. And I'm expecting Lena to be on Zoom. But I don't see her yet. She has to be excused for Zoom. Okay, so we'll work with what we have. There is an agenda and there are minutes. Each of you was emailed minutes and of course the agenda. So at a time that we can
Motion to adopt the agenda?
well, we don't have a quorum, so I guess we could, have it out there on the floor. But we could just follow the agenda for now. Is there anything that anyone wants to add? Okay. So we can follow it now and then adopt it when we have a quorum. And I am hoping Monique comes so that we can have a quorum. And we have a guest, pronounce your first name,
Shivani.
Shivani. You've been here once before, right? Or have you not? Okay, well, welcome and hope we'll see you again. Are you a student or?
Yes.
Are you a board member?
So I recently moved into Maine like 3 years ago. I'm currently in verse getting my
Oh, great, well, welcome. Okay, so the first item on the agenda after minutes are the announcements or any updates. I emailed out some articles, and okay, that looks like Monique. It was Monique. We have a quorum. Thank you.
Hey, Monique.
Hey, Monique, we've been waiting for you.
I hope not just me.
Yeah, you're our last committee member, 3 year on Zoom. Thank you for being here. I'm glad you made it safely.
Yeah, I almost wasn't, well, I wasn't gonna come physically because I didn't feel well. Here,
Oh, I'm sorry.
Yeah.
thank you. I appreciate it. You'll have to allow me to use the
Well, we
facility.
have started.
Yes, so it can start, but I'm gonna use the facility.
Yeah,
Sorry,
well,
everyone.
people on.
I see, good.
Yeah, so now, once you come back, we'll adopt the agenda and minutes.
Excellent.
Any announcements,
From me or just?
in general, but you know what, it might be a good time when you come back to become the candidate.
Yes,
Okay.
I shall.
Okay. All right, so, continue, let's move then to, Pauline, thank you for being here. We have you on our agenda every month. And so Pauline Ferranti represents New York City Department of Health and Mental Health. She's our liaison. And we look to her each month for any policy news, any news related to broadly to the community of the city. Things that we should know, things that might impact our district. And we might find out through the news, or we would rather find out through Pauline, and any others. So, Pauline, and then we have, Cameron, also who, this is his bailiwick, this is his area. And we asked him to really fill in too, especially on days that you're not able to be here. So we start with Pauline and anything that Cameron under Department of Health and Mental Health may have to add.
Thank you so much, Chair Henry and everyone. Good evening. Pauline from the Health Department. So some updates for this evening are we have a new health commissioner. His name is Alistair Martin, and he started his position last week. So we are looking forward to seeing what comes out of his administration in terms of, health equity, public health policy, and all of those things. So we're really excited to have him on board. With regards to respiratory illness, we are seeing an increase in RSV and flu. Thankfully, there's been a decrease in COVID. So that is good news. And as the weather hopefully starts to warm, hopefully these numbers will continue to drive down. As of February 20th, there has only been one case of measles in the city. However, we are still making sure that parents with children get back onto their vaccination schedule. We know that after COVID-19, a lot of children fell off the vaccine schedule. So we're encouraging parents of young children to make sure that they go see their pediatrician, get their children back on a clear vaccine schedule. And of course, the city and the state has made a commitment to make sure that access to immunizations will continue for all New Yorkers, despite the federal mandate to roll back some of the immunization schedule. So those are the major updates I have for this evening. I am happy to take any questions. Oh, actually, one more update with regards to 3333 Broadway and their Legionnaires investigation. So their building is working very closely with our water folks. I believe that they should have submitted their remediation plan to our team as of last week. Once that is approved and another, what they go through their round of cleaning, another round of sampling will need to take place. And then we will have to wait those 2 weeks for the lab cultures to grow to know whether or not the remediation worked. So there's still some time yet to figure out whether or not we can lift the water restrictions at the building. But again, they are currently working with our team to have their remediation plan approved and implemented. And then I will definitely let Community Board 9, and I know that your chair, Mr. Edwards, is very, very involved and is working very closely with the building as well. So I'm sure he will also know when the next round of sampling takes place, but I will definitely keep the board up to date about all the ongoings at 3333 Broadway. And that's it for now. Thank you so much.
Thank you, Pauline. There are a couple of questions. Monique.
Good evening, Pauline. Thank you for providing some of the updates. Going to 3333, has there been any discussion to do any surveillance beyond the 2 buildings that tested positive to make sure there is no other concern with the other remaining buildings?
Yes, I know there were ongoing conversations about that, and I believe it is the position of our agency that it is not necessary since the science doesn't point to any new diagnoses or any other diagnoses in the other towers. So the 2 individuals that were diagnosed with Legionnaire's disease were from Tower B, and the only reason why Tower A was also included is because only Tower A and Tower B share a water supply.
I see. All right. Thank you.
No problem.
And Pauline, when I attended this I think it was the last meeting of 3333, and the discussion was a terrific turnout at the building. And there was represented from Department of DOHMH, a medical advisor, or maybe he was some kind of manager. Do you have his name? Because unfortunately, do you know who is assigned from DOHMH to be there?
Yes. So actually, it was our Assistant Commissioner, Ricky Wong. He is the Assistant Commissioner for External Affairs in the office. So he oversees both our legislative arm and our community affairs arm. So he is technically my supervisor twice removed, I guess. So I have a supervisor above me, and then he supervises my supervisor.
Okay, and he's the assistant deputy commissioner.
I believe his title is assistant commissioner for
Okay.
community affairs.
Okay. Cause I, have some photos also, and I needed someone to identify him.
Yes,
Thank you.
so his name is Ricky Wong.
And does he spell Ricky the regular R-I-C-K-Y?
Yes, Ricky.
And Wong, W-O-N-G?
Correct. Oh, and I pulled up his title. It's Assistant Commissioner for Government Affairs.
Okay, for government. Okay, and do you know when they are slated to go back to the building or to check? I know you mentioned they're gonna see what the results are from this, this latest testing.
Yeah,
But
so I
if they
believe
think about when they should know that, is it a quick test to?
so it's not, unfortunately, it's not a quick test. So I believe right now they are in the remediation phase. So I believe that their third-party vendor that they've hired to bring on board um, should have sent in their remediation plan to our team as of the last week of February. And I believe it takes about just like a day for our team to review and approve, or review and suggest changes to their remediation plan. And then once it's approved by our agency, they go and implement the remediation. So the building and the vendor should be in charge of sharing exactly what the remediation plan looks like for the tenants, whether or not they are going to be, adding chlorine to the water, or, what other remediation plan has been approved. All of that should be communicated to the tenants. And then once that round of remediation takes place, then they will need to notify the tenants that are ready to sample again. And then they'll have to let people know that they need access to the apartments and to other places to collect samples. And then when that happens, then it's an additional 2 weeks for those samples to go to the lab, and then for those samples to grow, because it's a bacteria. So it does take 2 weeks for those. So yeah, for that process to confirm whether or not the remediation worked. So if after the sampling, the 2 weeks show that there is no growth of Legionella bacteria, then all is well and the building can return to normal water usage. However, if the samples come back and it shows that there is continued growth, then it'll be another round of remediation, another round of sampling, and then, waiting for the results, and then a clear go ahead, or, this process continues. So we are hoping that the remediation that is going to be happening either soon or very soon, hopefully that will work, and that their samples, when they do come back, will be clear.
Okay, and one other Legionella question. No one has forgotten the 9 buildings from the summer or fall. Just for the record, do you, and if you don't know now, maybe next month, we never really got I guess the same kind of follow-up as with 33 now. What was the process of eliminating, checking on everything, and remediation there?
So
Well,
the buildings that were involved in the community cluster over the summer, it was kind of a different evaluation because it was their cooling towers. And so it wasn't an internal water supply situation. So I believe what happens is they then are mandated to hire or have their HVAC people come in and do a thorough cleaning of their water, their cooling tower. And there really isn't, like additional follow-up as we do with building specific cases, because again, it impacts a larger, it's not the internal water that we're shutting off for a building or asking people to refrain from taking a shower in a building. It was, it impacted the entire community. But since it's wintertime, no HVAC systems are on, like the cooling towers have been shut down. And so there isn't a risk to the community right now. But I think there was legislation in place to have cleaning towers regulated more thoroughly and have more uh, regulations around how often buildings are required to submit testing samples for their cooling towers to the agency. So I think all of that has been prompted by the summer community cluster investigation.
Jordan?
I'm aware that it is winter and we're not using the cooling towers now, but it is going to be summer again.
Right. Mm-hmm.
And you just said yourself that it isn't an internal water supply issue. In fact, these cooling towers are poisoning a lot more people throughout the community. So yes, we should try less hard to make it better.
No, I didn't say that we're trying less hard. It's the way that we communicate with residents in a building when it's a building evaluation is more, we tend to go back more often just to share updates. But when it comes to the cleaning of the cooling towers, they're mandated to submit these, they're mandated to submit the results to the agency. So like we know that the cooling towers that were in question have been cleaned, and there is now more regulation in place that's being proposed to make it more stringent for these buildings that have cooling towers, to make sure that they're clean and that they don't impact the community like they did this past summer. So there is more work going on. But in terms of just going back and updating, the community on whether or not these cooling towers have submitted, it is not something that we have done, but I'm definitely taking this information back, stating that it could potentially be very important for people to know that all of the problematic cooling towers have been cleaned, have submitted, their testing and their samples, and we can absolutely look into how we could report that back to the community. That's absolutely something we can do. It's just not something we have done before, but I will absolutely take that back and make that a suggestion, because you're right.
Yeah.
It is very important.
So can you confirm to us either now, or if you don't have the information now, next meeting, that all of those cooling towers involved in this summer's Legionella outbreak have been tested or have been cleaned and retested and confirmed that they do not have Legionella again? Because you mentioned the new legislation requiring repeat testing. One of those towers wasn't even registered, and that was the Harlem Hospital one. So like, we as a community have no guarantee that the regulations will be followed. And so we have very little faith in the regulations unless you communicate to us as a community that these issues have been corrected.
I concur.
Yeah, absolutely. I think that makes a lot of sense.
Right. And then whatever documentation you can provide, even if you want to send it ahead of time, Pauline, as soon as you get it. I think we need to see and to let the community know, we want community to know that at least we're asking questions. Hopefully we're asking all the right questions, and that you guys are following through, because we do have a resolution that was passed on back in I don't know, maybe it was November. I can't recall the exact month. But we want accountability, and that's what we hope through the resolutions. That can happen, because we do need to have faith that our government is working on our behalf.
Yeah.
Yes, absolutely. I think that makes a lot of sense. I do know positively that all of the cooling towers that were in question were mandated to have a thorough cleaning. But I will be more than happy to follow up with our team just to see what other follow up was taken with those particular cooling towers. But also, hopefully the new legislation does come in place for more regular cleaning. I believe the current law is that they have to have biannual cleaning and provide samples to the agency. But I believe that there was call for like, every 3 months to do that. So I will see.
Yeah.
I will see.
Okay.
Yeah, I mean, I think that makes a lot of sense. Or in the very least, before the warmer weather comes up, that all buildings that have a cooling tower should be mandated to clean prior to turning on. I think that makes a lot of sense too. So I can definitely look into the proposed legislation and share that with you. But I know that the Senator Cordell Clare has been very active in this, and I know Councilmember Abreu as well. So I will definitely follow up with their teams just to see sort of what is being passed in the state and what's being passed in City Council to have more oversight over these buildings that do have cooling towers.
Would you have access to either proof of cleaning or proof of testing for these
Yeah, the
buildings?
documentation.
Because if you
Yeah,
could share. community
Yeah,
board.
I will definitely look into that.
Thanks, Jordan. Monique?
On here, I don't know if there's gonna be more conversation around vaccination, because you have
Oh, I was
Pauline
gonna ask you something about that.
and Cameron, are both listed, but I wasn't listening 100% when she was talking about the status of vaccination locally. I heard she said there was only one measles case in New York, and I didn't hear the other stuff in
There's
terms
an
of flu and.
increase in RSV and flu, but decrease in COVID.
Okay, I guess in terms of what steps is the city DOHMH taking in order to try to get those numbers up? So that more people don't get sick, if anything. That was my question.
And maybe you can answer at the same time. What I was thinking about right before Monique asked the question is, what are we doing, or is Dr. Martin, is he a doctor? He's a commissioner, but that doesn't mean he's a doctor. He's a doctor.
Yes, he was an ER doctor. Yes.
Okay,
So, and how proactive is he, or what is the posture of DOH in encouraging measles vaccines and some of the vaccines that babies not preborn, Lord, right after they're born, within the first 3 months or 2 months, the schedule of vaccines? How proactive?
Yeah, I think
Doctor
right.
came out, he was like almost frantic, get the vaccine, get the vaccine. And everyone was wondering, why weren't you saying that before with all the outbreak in the country? But so now it's like they're on their heels.
Yeah, I think our previous acting commissioner, Commissioner Morse, did come out very strongly after the federal government sort of rolled back some of the vaccine mandates federally to say very strongly that New York City, we support the previous vaccine schedule for kids, the pediatric vaccine schedule, and that we're going to promise that all New Yorkers would have access. Governor Hochul also made that commitment that New Yorkers will have access to vaccines. So both, Commissioner Morse, and the governor came out very strongly stating that the old vaccine schedule should be followed. All school-age children who attend public schools are required to be on their vaccine schedule, and they have to show proof of vaccine to attend public school. So that helps keep the vaccination numbers for our youngest New Yorkers good. But again, it's, older people don't know that the MMR vaccine does decrease over time and that you potentially might need a booster. So all of this is we do try to provide, as much educational material as we can. We go to health fairs, we table, we try and, get this information out through our school nurses. So if you have any suggestions on how we can better educate the community, we're always open to those. But I believe we did have a vaccine campaign that went on. It was on social media. I believe it was in the subway stations. So, we do try our best to make sure that people know that immunization is the best way to prevent serious illness. We don't want to see diseases that have been eradicated in the past come back, like polio and measles. And so we do try our best to have these educational campaigns. But again, if you guys have any other suggestions for how we can better do our public engagement, we are all ears.
Thank you so much, Pauline. Let me, I have a request. Can you email to me the names of, the new people, oh goodness, they're at the office on the east side but they handle West Harlem as well, for DOHMH with
Oh,
materials.
the Health Action Center.
That's what it's called, yeah.
So,
the health-
yes. So the Harlem Health Action Center, that is run by Padmore John.
By Padmore, okay.
Yes. So he's the best. And I know that Padmore is very close with Community Board 9 as well, but he's in charge over there. He's the right man to contact. But I will definitely send you some other emails of folks who work over at the Health Action Center.
Yeah, and also, we had a presenter come twice to talk about different trainings that they have for people, and sometimes they don't get the enrollment that they want to need. I don't know if that person is still there, but I don't have the list in front of me, so, but if those that have community outreach programs, if you could send their names, position, if there's a list or screenshot of a page that has, the listings and phone number, that would be very much needed, if I could have it real soon in a couple of days.
Absolutely. Yes, I will send that over to you as quickly as possible.
Okay, thank you.
You're welcome.
All right, anything else? All right, so we look forward to seeing you, hearing from you next month, also, April. And you'll be getting another bit of information too regarding materials needed for our public health forum. Okay,
Perfect. Thank you so much.
thank you, Pauline. Cameron, I don't know if you had anything that may be a little different, or if you might want to add related to that, or you can do it within, we have a whole section for you, updates, let's see. All kind of information, children's health data, the intern who was working, with the two committees, if you have any follow-up on that project. I think Legionnaires was pretty much covered, and I wasn't sure Victor was gonna be here. But I think that was pretty much covered. And then I know you wanted to talk about the New York State Health Act. So, take it away. It'd be interesting to, I guess, go from top to bottom. On the intern, or any follow-up, and when do they finish their work? Is it April? Is he there?
Hey, Laguida, how's it going? Yeah, and I apologize for not being able to be there in person. I'm not feeling particularly well today, so I might actually drop off and go to bed after after my update. But in terms of in order of sort of how you were asking, I think I can briefly talk about the fellow that we have, and I can actually.
Interns. Correct that.
I'm sorry.
No, I said internist, you're right, it's the fellow, I'll correct that.
Oh yeah, all good. But yeah, so we were able to chat got Signy on the call just for a little bit more, institutional memory on some of the housing policy stuff. But and I can probably pull up my screen to share,
Okay.
the most recent update. And this is like very much like a draft analysis. So, I don't read for
Yeah.
style, really just for content, but essentially, so this is a full housing and supportive resources analysis for Manhattan Community Board 9. And so we broke it into a few different sections, talking about sort of the AMI mismatch, the gap between sort of like, quote unquote, what is determined to be affordable according to like what different buildings are proposing versus what it would actually be affordable for the neighborhood based on the actual median income of those districts. Talked about the production pipeline, and some of the different developments that have been proposed or built or are scheduled to be built recently, and how those what the affordability for those different developments would look like. And then eventually we put a lot of this stuff together. We also have a section on like the different service ecosystem, as well as a section on the density of supportive housing. But essentially what we take that all together and sort of Arnav, our fellow, created sort of like a proposed decision-making framework that looks at sort of holistically a lot of the different criteria that the community board has historically used to evaluate a housing proposal, and sort of tries to put data to that, to help this community board make more sort of evidence-based or more sort of analytically informed decisions about like, all right, is this actually a good deal in terms of the amount of affordable housing that like a new building or a new proposal is giving. So obviously I'm not going to go through this line by line because it's 50 pages, but I think there's a few highlights that I can pull out. I think this was a key point in the document that I think I definitely resonated with me specifically. Sort of the policy position of support with conditions, talking about, the report does not oppose supportive housing in CB9, but rather it establishes that any new supportive housing approved in CB9, particularly in tract 219, which was a tract that was found to have a particularly high density of supportive housing, must be evaluated against two criteria: whether the project meaningfully serves the deeply low-income population it's actually claiming to target, and whether the geographic distribution of the project worsens a documented saturation crisis in the district's poorest district in the district's poorest tract. So there's a bunch of different research that goes into this to determine like whether specific neighborhoods within CB9 are more oversaturated than others. Talking about like what would be a fair level of median income to set future proposals at. And it sort of boils down to around about, sort of between 40 and 50% of AMI, as opposed to like the 60 to 80 to 100% AMI that have historically been proposed for projects in the past. So we're gonna have Arnav give like a full presentation for this, in the future. I think probably at potentially at the next exec or general board meeting, depending on the scheduling. But you can tell that like he's applied a lot of thought, and a lot of research has gone into some of the conclusions that he's brought. And so we're really proud of the work. And if once this is finalized, once we get it all nice looking and with the board's approval, I think it would be cool to publish it. Just to give Arnav a little bit of credit, and also to allow this document, if it reflects some of the values of the board, to be like a potentially a model that other community boards and housing organizations can use for sort of addressing the affordable housing crisis, but also supporting folks who are supporting some of the communities like Harlem that have been sort of like designated as, I would say, quote unquote, dumping grounds for supportive housing, shelter housing, like other things that are common goods, but are potentially over concentrated in certain areas to the detriment of other But yeah, so that's very briefly, talking about some of the stuff that Arnav's done. Oh, what's up?
Cameron,
Yeah.
this is what he put together, pulling together research, from whatever sources. But this is his writing and his table of contents.
That's correct.
It's a lot of work. It's excellent.
Yeah. Yep.
Yeah,
Definitely.
very nice.
Yeah, it goes down into a level of detail that I think is necessary for the work that we're doing, but I think also like very impressive, especially considering that like Arnav does not have like a housing background. So I think this is definitely impressive, and I think it's longer than like I think we're basically referring to this as sort of like a master document, and then we can use it to create one pagers as sort of the fertile ground from which we can write one pagers, op-eds, different white papers, position statements, whatever we want to do with this in the future. So I think it's crafted to be able to like outlive the fellowship itself and be able to be useful for the board for a few years in the future at least.
Okay, Monique has a question.
Just as a quick question, you're right,
Yeah.
it's great. I mean, I guess that's gonna be part of his practicum as he gets ready to graduate. The stuff that we glean from what he has written, will it be compiled into some sort of resource that goes online so that it's easily accessible? Because I think that was a part of also his assignment to help us figure out what is in our community and can be accessible in one place.
Yeah, so that's actually a different. So there were essentially two separate projects that we had him work on. The first project is sort of closer to the one that you're referring to, of sort of like a resource guide
Yeah.
for community members. And that one, I think it's more or less finalized. I think we're just sort of, waiting for to give him the opportunity to present it, and then
Okay.
we'll send that off to, to Yutha and to the staff to put that on the website and to potentially come up with a plan to present that information in ways that are to figure out a couple of different ways that we can make that more accessible to community members. And so that's going to be the next steps for that document. This is like I would say it's definitely not like exclusively internal, like it's meant to be a resource for everybody in the community, but I think it's sort of a document that sort of guides what the board's historical position has been around sort of different housing developments and with considering the priorities that the board has had in terms of affordability in the past. So it's sort of trying to take those values, and I think the stated district need statements that have been sort of recurring of we need affordable housing and we need to address poverty, and trying to put those into a document that distills those from the perspective of housing, if that makes sense.
No, it does. I mean, stable housing leads to good health. And when
Yep.
you're healthy, you can have a job, be productive, and do all those things that we want a person to do, which is why it makes sense to tie health and housing together, because they are very much interrelated, which I'm sure we didn't talk about it fully, but I'm sure there's more health stuff in there that we probably can't go through because there's a lot.
Absolutely, yeah. I think all of these different factors that we were looking at have sort of health outcomes that are linked to them.
Okay.
There's a documented relationship between lack of affordable housing, lack of stable housing, and worsened health outcomes across a range of different domains, both
Right.
short and long term outcomes. And so I think that this is something that we can definitely tie to health. That wasn't like that wasn't a specific ask that we made, because I think that was a little bit outside of the scope of sort of the proposal that we wrote for this fellowship. But I think that because we have a lot of this, Arnav did a lot of this sort of groundwork, I think that it gives us the opportunity to take a lot of the the charts and graphs and figures that have already been made, and we can sort of correlate those to like, the publicly documented research on like health outcomes and be able to say like, all right, because we, know that, there is this huge gap between, area median income for our district and the mean, available unit for this district. We know that there is like this disparity in terms of, the units that people can actually afford and the units that are available for folks in the neighborhood. And so that creates the housing instability. And we can see from this other public, published research, peer-reviewed research, that sort of gap is linked to many of the healthcare outcomes and disparities that we end up seeing in our community. So I think it gives us the ability to do that in a bunch of different, really interesting ways. So yeah, definitely excited, for him to give like the full presentation, and excited for everybody to be able to see, the final product when it comes out.
And if he wants to come, well, let's see, if he wants, I don't know if April his last, when is his semester, when is this? I think they were due.
So he graduates in May. I think we're trying to have this done by April. And so we're trying to have the presentation, in the next sort of month or two.
Right. Okay, if he wants to do a preliminary with a smaller group, our committee, that's fine too, that might make him more, even more comfortable, maybe a portion of it, not the whole thing, whatever, that the offer's there.
Sounds good. I will pass that along, and we'll see. We'll see, which presentations or which times and dates we can make work for us and for him in terms of like, committee, whether it's committee, executive, and then general or some combination of that. But yeah, so that's any other questions on this specifically?
No, but I don't know, I don't know if you wanna do children's health data, if you had an opportunity to really look into it, but I know if you wanna skip to health act, feel free. But
Yeah, I'll probably skip to Health Act. Just, I think Pauline covered, some of the most relevant, children's health stuff pretty well.
and
Yeah, and Legion has as well. But yeah, so I think the other thing that I wanted to share, and folks might have seen this, on the coming from the community board listserv last week, was there was actually a rally starting at Harlem Hospital. It finished over at the Senate office building. It was a food, housing, and healthcare for all rally, sponsored by a bunch of different organizations: Urban Justice Center, ACT UP, Safety Net Project, Rise and Resist. I think it was, I think a few different organizations that co-sponsored it. Just community members coming together to protest cuts to vital safety net programs, SNAP, Medicaid, public housing, and protesting those funds being invested instead in tax breaks for billionaires, ICE, and foreign wars that we have no business being in. So groups from the community came together. I think it was a really productive rally. I was able to be there and join and support. So I think it was a really good time. But I think it inspired me to speak to this board, just to amplify some of the message of the rally and speak about an issue that I think is personally significant, which is the New York Health Act. So I'll just jump in, and everybody can see my screen all right?
Yes.
Awesome. So, this was the rally. Folks, I think, had a really good time. We also had folks from youth activists. I think it was Transforming and Growing the Tag ambassadors came out to speak. So I think it was a really fun time. But yeah, so if folks aren't familiar, so there's essentially a concept called single payer universal healthcare, which it stands in opposition to the healthcare that most of us are generally familiar with, where essentially you get your health insurance from either via your employer from, one of the few 4 or 5 major insurance companies. You pay a premium to benefit, to have access to benefits, but then still you may not even be eligible until you hit a deductible. You also are going to have to pay a copay. And then even with all of that, you might have to, get a pre-approval or a prior authorization. And then even after all of that, your care might be denied for reasons that have nothing to do with the actual sort of, medical necessity, but might just have to do with, the bottom line of the financial institution that is your health insurance company. And so in contrast to that sort of complicated, convoluted system with all of these loopholes, and that really actually restricts most people's ability to get the care that they want because they're trying to do sort of mathematics in their head about whether they can afford it. There's this system that has been adopted by every single other industrialized country in the world, which is sort of like a single payer universal healthcare system. In this system, both businesses and individuals pay income-based premiums to the government, and we'll get into whether like this is state or federal government, which would then fund a public health insurance company that would reimburse doctors' offices, hospitals, other healthcare facilities directly for the care that you receive. No longer would you have to pay anything at the point of care. This would all be sort of handled by the interaction between the governmental insurance sort of care agency and the care providers directly. So there's no restrictions on your ability to actually access the care that you want. And so when it comes to this, I think this is something that obviously there's been a lot of conversation about on like the federal level. Folks have been talking about sort of Medicare for all for like many, many years. It's been like extremely popular and has avoided passing for reasons that take a while to get into, but I think that start and end with sort of special interests purchasing power in many of our federal elections. But organizers and activists have historically seen that one possible way to make the idea of universal healthcare more palatable on the national level is to implement sort of like a state-based trial or experimental version of this. And one version of this that has been taking place and building steam in New York State is called the New York Health Act. So that's a universal comprehensive healthcare plan. So it provides care to every single New Yorker, regardless of immigration status, income, ability, wealth, or employment status. It eliminates all of the financial barriers that have traditionally sort of prevented folks from being able to access care under our existing system, stuff like premiums, copays, deductibles, coinsurance. There is no in-network, out-of-network under a New York Health Act. And it would provide comprehensive care, unlike care that, many of us receive, or like maybe you're missing coverage for dental. Maybe you're missing coverage for mental health care. Maybe you don't get coverage for preventive care, or prescriptions, or reproductive care. The New York Health Act acknowledges that no, you're actually a human being that has teeth and a brain, and so you should probably get care for both of those things, in addition to care to prevent illnesses, because there's no financial incentive to this organization to deny you care for things that are done preventatively.
Cameron?
Yeah, what's up?
Yeah.
Yeah, go for it.
I
Actually, yeah, I could take one question, but then this is going to be relatively short. So if it's a save to the end question, I can also take them at the end.
Okay, go ahead,
All
Cameron.
right. All right. Yeah. And so in terms of affordability, I think that this has been something that has both been reflected at the federal level with Medicare for all, is that, turns out when you eliminate like large sort of insurance companies that really exist and pharmacy benefit managers that really exist as middlemen that introduce barriers at each stage of this process, you actually end up saving money. So you're actually able to expand care for the entire population. You're able to reduce the cost of care because you're not having to jack up the prices because you're expecting, to haggle with an insurance company or a pharmacy benefit manager. And you're actually able to, generate long-term savings. So if you actually took the total of all of the premiums, deductibles, copays that folks are paying currently under our current system for covering just a portion of the population that is insured, you actually are and took those and funneled those in an income-based distribution to a New York Health Act, you actually generate a savings of more than $17 billion. And this was, this is not an analysis that was done by some some lefty activists in their basement with Excel. This was an analysis that was done by the Rand Corporation, which is hardly like a left-leaning organization, and determined that this actually would save the state a significant amount of money while expanding care to folks who currently do not have access under the current system. And so under and I think that a lot of these are just sort of a lot of charts that restate like, hey, we're actually paying way too much and receiving far less care. This sort of talks about, the overhead costs of all of the different sort of private insurance companies. So WellPoint, Aetna, Humana, United Healthcare, each take a huge chunk, 15 to 20% overhead out of these out of the existing programs, while public Medicare has an overhead that hovers around 2%. Additionally, I think under the regime that we are all existing under, we are currently experiencing drastic cuts. If you are getting care from sort of any federal source, that care is, constantly under threat. Like, you might, 1 year if Congress decides that they want to cut or increase the restrictions or limit the availability of Medicare or Medicaid or other types of sort of, subsidized healthcare, you might lose access to care. And currently, millions and millions of people are already scheduled to lose access to care just via the loss of the subsidies that are provided under Obamacare. So New York Health Act would be one way to Trump-proof or, honestly, Republican or Democrat-proof our healthcare that we're receiving, so that it's not susceptible to the whims of any given administration to cut funding for it. And so I think, there's a bunch of different ways that this has become a law, but historically, this is a bill that has had, enormous support in the New York state legislature. It actually passed in 2015, 16, 17, and 18 with more than 2-to-1 majorities. That's super majorities on the Assembly side. And it was reintroduced in 2023 on the Senate side with more than 34 co-sponsors. So actually, if you look at historically the number of folks that have, supported the New York Health Act, it's been majorities in both sides, in both houses of the New York State Legislature. So this is something that definitely folks like to say that they're for, but I think what is the gap is that, we need more folks to have the political courage and will to actually, demand that this is passed, as opposed to just sort of saying that it's something that they vaguely support to score a few political points. And so now I can go to question and answer. I'll drop out of my full screen share, just so I can go look at everybody's faces.
Camera the same or similar to or patterned or modeled after the California plan, because they're very progressive. And I know that once funding was about to be cut in November, Gavin Newsom, the governor of California, mentioned grouping together the states in the West to form a health kind of a consortium to cover it so that so many people wouldn't lose. And then I started hearing about out east, I think Massachusetts wants to combine with a few of the states there. So is this all part of you may not know the answer, but anyway, is this all part of that same thinking or pushback on what the administration is doing, or is this something we've had for a while but hasn't been activated?
So this is currently a bill that has not been passed. There's no state in the country that currently administers a universal healthcare plan. You know, there are states that have sort of various degrees of generosity in terms of their healthcare safety net, but there isn't any state, at least not that I'm familiar with, that has, you know, completely universal healthcare. And that's, you know, that's, I think, you know, the thing that you
Yeah,
mentioned, with Gavin Newsom, I
so
think that
he's
there are a couple of different
saying,
ways to that different states have proposed to expand coverage, but you know, still maintaining like the private infrastructure that you know honestly generates a lot of the waste in this system is, I think, one of the things that is prevented some of these bills from being implemented. So I think this.
and can you inform us if they're ready for a resolution or at such time as long as we agree with it, present a resolution when they're, just keep us informed on that
Yeah, I
part?
mean, you know, if and this was sort of gonna be my ask is like if this is something that our board feels like we would be supportive of, then you know I would be happy to write a resolution
Mhm.
that we could sort of send over to all of the statewide representatives that we're associated with to call for you know their support for you know the New York Health Act.
Okay, that'd be great. So we'll vote on it in committee. Hopefully it's good, it's a good start anyway. Jordan?
Hi Cameron, just full disclaimer, I'm gonna vote for whatever resolution you write supporting this, no matter what your answers to these questions are.
But
I've, my parents campaigned for single payer under the Clintons, like it's, this is not, I've been raised to like this idea. In a state by state, version, I have two questions about how it would be handled. One, if someone is a resident of New York but employed in another state, so for example, I live in New York, but the company I work for is headquartered in Minnesota, um, would that be handled, like I do pay taxes in New York, would the employer taxes just come out of my paycheck the same way like employment taxes do? And my second question is, if I were to travel to a different state, like if I were to go to California and I don't know, break my arm, and if I went to a California hospital because I had broken my arm, would being a New York resident cover healthcare in California? Because I know that say if I went to Switzerland and broke my arm, I would have to deal with the Swiss healthcare system. That would be preferable to the US healthcare system, but
So is it portable?
yeah, basically, could you take your New York insurance and use it in another state? And if your employer is not in New York, would it just work the same way as my current employment
That
taxes?
could be a recommendation for them to look into.
Yeah.
Yeah, I mean, so for both of those questions, my tentative, and this is something that I would need to look into to confirm, but my tentative initial response would be yes to both. Is that it would operate sort of based on reimbursement. So New York, if you you know got injured elsewhere, and then you know you where you received the care you would then be able to New York State would essentially reimburse the provider that you were receiving care for in the state that you end up going to. I think that was something that they ended up litigating, but I'm in contact with some of the folks that are like, you know, far more versed in this legislation than I am. So I can reach out to them to confirm and get back to you. And then for your first question, yeah, so it would be based like you would still if you are a resident of New York, you're receiving care regardless. The care that you receive is not tied to like what you're putting into the system. You get no extra benefits if you're, you know, paying like millions and millions of dollars of taxes for, you know, everybody's getting the same high level of care. In terms of the input, yeah. So if you're paying taxes in New York, as a New York resident, I don't know if it necessarily is linked to where your business is headquartered, but if you're paying New York taxes, it would be a part of your New York.
Cameron, can you speak up a little, please?
Yeah, some competition
Sorry,
with our above ground trains.
We know you can
Sorry.
project.
Sorry, yeah. Can you hear me now?
Yeah,
Yes,
thank you.
Okay. Yeah,
Just
so it
that
would-
last part.
got it. Yeah, so it would be my understanding, and for both of these, I will definitely go back to the folks who are, the authors on this bill and make sure that I'm clear. But my understanding is that, the amount that you are your taxes are based on, where you are a resident. And so if you're paying New York state income or payroll taxes now, then that would be part of, the taxes that you're paying. Same for like if you're a business, if you're already currently paying New York taxes, then you just, instead of paying like the premiums to the insurance company and then the taxes to the state, you would just pay, a smaller amount of taxes to the state. So it would replace the premiums that you're currently paying. Yeah, but I can go back to the folks and confirm both of those things.
Cameron, this is hi. This is not a new system. Massachusetts has it. So to that question of if something happened outside of the state, what typically happens is the same thing that happens in Medicaid. Your state insurance will cover that event that happens outside of the state. So Massachusetts has this that New York is trying to catch up to now.
Okay.
I thought it started somewhere.
I'm not sure if that I don't know about that necessarily, whether Massachusetts has like universal healthcare. I think at least in, this might be, I might be yeah, I'd have to look into that to see exactly what the structure of the system in Massachusetts is. But
Yeah, so they were the pioneer back in 2006.
Okay. If you're talking about, that's Romney Care. That's a different
Obamacare was
system.
based off of, and Obamacare doesn't have a single payer component.
Yeah. So
Yes,
yeah,
stars.
Romney Care is not a single payer system. It's sort of like a marketplace system. So it achieved like a very, very high level of healthcare coverage, but it was still like a privately distributed system. So folks were, gaining access to private insurers through a marketplace, and that was sort of like how healthcare was managed through Romney Care, or the Massachusetts healthcare plan.
Cameron, 2 questions.
Yeah, and I think
I'm sorry.
Monica, I think you had your hand raised.
Me?
Yes, so does this take into, I'm sorry, I'm muted. Hi, does this take in?
Yeah,
Huh?
I can hear you.
Yeah.
Okay. Does this take into account the cuts to Medicaid, and does it take into the account that many of the health clinics, the federal health clinics, are going to be closing in our communities?
Yeah, and so I think what this actually does is it actually sort of provides, a lifeline to those sort of clinics. So, with
A safety net?
I'm sorry.
Oh, no, I was just asking, like a safety net.
Yeah, so under a lot of under the current healthcare cuts, like there are numerous clinics that are not federally run, but they are heavily reliant on federal funding and federal reimbursements. And as those federal funds sort of ebb and flow, depending on the administration, that's something that deeply impacts the bottom lines of those federally qualified healthcare centers. Because, if Trump or some future president decides like, oh, actually, we don't want to provide the level of reimbursement that we have been providing, or maybe we're going to kick a bunch of people off the rolls, which has, essentially the same impact, that makes it a lot more difficult for a lot of these centers to sustain themselves. And so what this does is, by sort of increasing the population of folks who are, just generally insured, and also, providing a steady revenue stream for a lot of these, health centers, whether they're federally qualified, whether they're academic health centers, whether they're safety net hospitals, it says like, we're actually not going to be oscillating our reimbursement rates. We're not going to be depending on, what an individual insurance company. A lot of y'all have probably been familiar with, basically every year, New York Presbyterian and Montefiore, or one of the major academic medical centers, gets into a little fight with a large private insurer. I think this year it was like Aetna got into a fight with NYP, and then what was it? I think it was
Sinai is also Sinai
Metro
has
Metro Plus, Metro Health also got, and until those fights are resolved, folks with those insurance types aren't able to access care at those healthcare institutions, and so that eliminates the baseline insecurity that folks have with just having private health insurance, by providing like a very consistent, reliable level of funding to a lot of these centers. And so all they have to worry about is getting patients in the door, instead of, getting patients in the door and then wondering about whether they will or will not be reimbursed, or, getting wealthy people in the door to subsidize the poor people that they want to care for. So it eliminates a lot of those tensions that exist under this current system, while providing additional stability.
And Monique?
Yeah,
I
go for
think
it.
Heather?
Is this equivalent then to like Medicare for all? And I'm gonna, I guess I didn't hear the complete answer to the Medicaid question. Does it eliminate Medicaid? But I'm more interested in knowing, is this sort of like, Medicare for all?
So no, this does not eliminate Medicaid. So folks who are currently on Medicaid would still be able to get care via Medicaid. So what this would do is, and this doesn't actually technically, eliminate private insurance companies. It just makes it, unprofitable to be a private insurance company. And so,
and
yeah, so it makes it essentially unsustainable for them to operate in the way that they've been operating, because when they're competing with, folks who are able to get the care for free, then there's really no incentive for anybody to sign up for private insurance. And
But
so
Cameron,
this isn't exactly Medicare for all, but I think I think the easiest way to understand it is sort of like an analogous state-based example of like how Medicaid for all or Medicare for all could operate.
So is it like for New York, is it like the essential plan without the stigma of being on the essential plan?
Yeah, I think that's I think that's a closer thing, but I think it's sort of like, everybody gets the essential plan plus, sort of like a jump-started, boosted version of the essential plan, where it's not just, it's not a baseline level of care. It's like a very comprehensive level of care, without, anybody paying, additional money. So everybody pays less and gets more coverage under sort of New York Health Act.
Monique and then Edwin?
One, do we know where things stand in terms of the reintroduction of this act again? That was my first question. Tied to the fact now the governor is running for election, so maybe a stronghold or something we can use as leverage to, to get her to reconsider it more strongly. And I guess I could look this up, but do we know who is the head of the health committee on the state level? Is it a state person?
So question one, in terms of reintroduced, it's already been reintroduced for this session. I just saw there was an announcement that there was like an additional co-sponsor that was added on the Senate side. And then in terms of question two, yes, that's actually exactly what sort of organizers have been doing, is sort of using, Governor Hochul's reelection campaign, as well as, all of the chaos that is happening at the federal level, as leverage to apply pressure both to Governor Hochul, but also to state legislatures to pass this bill. And in terms of three, I don't recall off the top of my head who is responsible for it on the assembly side, but Senator Gustavo Rivera, who is, sort of represents the, I think it's like sort of the North and Central Bronx, is the person who is, who has been the co-sponsor of it for several years on the Senate side.
Okay, thank you, Karen.
Then
Sean?
Edwin,
You said Sean?
Yeah, I was gonna ask if
I was
Sean
gonna
Gray was.
say, Cameron, that to add to this, if we can remember just recently, one of the issues with the nurses strike was insurance, right?
Mhm.
Yes.
And this is something that if you think about it from an employee and from a small business perspective, it can spark entrepreneurship because now when you have a business, insurance is not something that you're thinking of because that is the most expensive ticket for any employer in the United States. Additionally, we will not see that being used as a golden handcuff for employees by big employers when you are, working for them, because everybody, like you said, will get the baseline care. And in countries that have universal health care, the private market doesn't disappear, right? Your employer can decide, hey, we're going to have a premium plus and, whatever on top of that. But at least at the most basic level, the patients and the providers are not subject to this system in which, you know, basically money talks when it comes to healthcare. Everybody will have access.
Exactly, 100%. I neglected to mention sort of those two. Those are advantages sort of universal healthcare more generally, but it provides the ability for folks to have a lot more independence from their jobs. You're no longer tied to your employer because you're scared of losing your healthcare.
Yeah.
It gives you the ability to have a
Karen,
lot more.
speak up, please.
and train again.
So it just like Edwin said, this gives folks the ability to have a lot more flexibility and leverage in their employment situations because you're no longer tied to your employer because they are the only one who provides you with healthcare. So now that you don't have to negotiate for healthcare or you don't have to stay at a potentially a hostile or unhappy work environment just because of healthcare, it gives folks a lot more freedom to, move jobs, to change jobs, to start their own ventures, to become entrepreneurs, and to do a lot more independent things, to organize within their workplaces. It gives folks a lot more ability and freedom to kind of fulfill all the other things because you're
Yeah.
not scared of losing access to healthcare because of your employment status.
Karen, the nurses at NYP, they were without health insurance for 41 days
Yep.
when they were on strike.
Yeah. And that would be something that potentially that, under a New York Health Act, they would not have to do.
Yeah.
So it would give them, the agency and the ability to hold out for longer because they're no longer worrying, oh, wait, I'm going to run out of my medications because the hospital maliciously cut off my insurance.
Yeah.
So I think there's a lot of sort of, I think Edwin mentioned a few of them, but there's a lot of sort of, if you just kind of use your imagination, there's so many sort of outflow benefits from not tying healthcare to employment.
And our seniors too, Cameron, a lot of times with, in healthcare, even though they do have Medicare, there's a gap. And by having this, it would allow folks, to sort of, reallocate that, those funds, to housing, like we were speaking about here earlier, and to food instead of just going to healthcare.
And
Absolutely.
just even with healthcare, cover things like dental and eye care, which is very woefully inadequately funded as a person who ages and you need those services more. So it sounds like it's a win-win. Let's write the resolution.
Yeah.
I will. So what I'll do is, I honestly wasn't sure. I didn't know where the support was going to be, but I think what I can do right now is number one, I'm going to look back to make sure I can get the answers to some of those questions that I'm not entirely confirmed on, but I'll get the answers to those questions. But I'm also going to see if they have any sort of sample or template resolutions that I can sort of adapt and send over to folks here. And so if we either what we can do is maybe try either to do what we did last time with some of the you know, the heating resolutions, where we can try to do it by poll, like after this, to see if we can get it before, you know, executive committee, so that we can get it out this month. But if not this month, then definitely, you know,
Yeah, I think
by April.
even April would be good because I don't, Cameron, you might know better than I. Most of their voting will take place in May,
Yep.
I think, or April.
Yeah,
Yeah,
so I mean,
make sure
with the state, yeah, and I agree, Laquita, like, you know, obviously, and this is always, you know, fun with state legislation, is that it's always, you know, it's basically the state is only in session for about 6 months out of the year, and the majority of that time is spent kind of waiting for the budget to pass, and then it's like a mad dash for the last few weeks of session to pass all the things that they're trying to pass. And so for stuff like this, it's always the sooner the better. The sooner that you can get, you know, your voice out there and that you can express your support for something, the less the greater the chance is that it will not get sort of buried under all the other things that are going on. So, you know, I'll try to put together a resolution with enough time for folks to look at it and express
Yeah,
opinions and feedback.
and that's good because there may also be questions that come up in March with general board that gives us April to get back. So yeah.
Absolutely.
Can we
And
put time?
Cameron, I
Yeah.
will say that March 10th, the nurses, they're going to
Where is on the
to
house
the
side?
to the
This
to the
you?
state legislators, and
Sorry.
this is one of the items that they're
Start over
advocating.
again, Evan.
On
Start
March
over.
on March 10, there's a lobby day happening with the nurses union. And they're representing, I think it's 42,000 nurses in the state. And this is one of the big items that they want to push forth. Because, you know, of all the stuff that we have been talking about here. So if this is, you know, pass, you know, the result, like it just adds to that because, you know, when we are up there, we can say, look, your community boards, they're also on board with this stuff.
Yep,
Yeah.
absolutely.
Sounds good.
I'd be pro voting on this via email.
Yeah, I was gonna,
Yeah, but that's not gonna be a problem.
can we get
It's
the,
just for the committee, at least.
can we get the representatives sponsoring
That's a good question.
the bill to come and present, either Gustavo Rivera or whoever is the equivalent?
And even at
Since
the
he's
general board.
He's downstate, so I'm sure Gustavo would be willing to speak at, you know, community board level.
Yeah, at the general board, that would be good, have a
Mhm.
segment, you know, guest speaker from on this health act. I think that's big. I think that would be.
That way we can press our locals as well.
Mhm.
Yeah.
You wanna reach out to them, camera?
I will, what
Which-
I'll reach out to my contacts don't go that high, but I will reach out to the folks that I know who are working on the New York Health Act. And I'll see who they, you know, if
And-
one of them or if they can get, you know, Senator Rivera or one of his staffers or someone to come to the general.
And you know, maybe even you don't know if Cordell Clear has signed on.
She's a co-sponsor of the New York Health Act. And
Oh,
so,
then we could get her to maybe even make a contact for us,
Right.
you know, the other person.
Yeah, reach out to her colleague.
Yeah.
Ask him to come and.
Yeah, and she come with him, you know, to introduce. Let us know who the co-sign, yeah, that's what they're called. The signers are, and then inside, inside the committee, then maybe there are a couple of us that could help, you know, do some calling.
okay, yeah, so I'll see if I can get a resolution to y'all in the next couple days, day or so, and then I'll also share with y'all the list of co-sponsors of the New York Health Act on the Senate and Assembly sides.
Yeah.
And I'll also reach out to my folks to see if anybody would be available to come and speak and to answer any of the questions that might come up before the general board.
You know, who's head of the Senate? Is that still Oh, what's this? Who's the head of the Senate?
Andrea Stewart Cousins,
Right. And then the Assembly?
Carl Hasty.
Okay, so the same ones, okay, good, okay, okay. Thanks, Cameron, that was terrific. That was.
Absolutely, thank you.
Yeah, any other questions? I don't see any other hands up. But that was terrific, so just we'll know when you've emailed, I guess, if you wanna submit to the executives, I guess. Even if we hear from you by Monday, they usually want the paperwork in, and we'll let them know there's a resolution coming. And then as long as they get it by Wednesday, that could work out too, or Tuesday.
Sounds good to me.
Give yourself some time. Okay, thank you so much. Edwin, did you have something else?
No, that's all I have.
Okay, so I don't believe that we have any other West Harlem Development Corporation grantees, but I put it here just in case I might have missed someone. But as a matter of fact, I think, well, maybe Ibria did come, Ibria Foundation came early. It was last year. And so we have satisfied, hearing from all of our grantees. I believe there were only something like 9 this, or maybe 12. I have to look at it again, but it wasn't as large a number. But they were significant, and we have heard from them. If another comes up, April, they still have time in April to present. So we're done with that. Before I go into what's still new business, is there any old business? I think, Edwin, I have to, the idling, trucks and all, were you able to reach out to Councilmember Abreu to follow up on the one school bus that was really in violation, with the parking? And wanted some break from the council member in terms of the fee? Guess he's not there. So it may. Okay, oh, there he is. If not, we might need more time, but if not, but I think what's going on there? You see where I'm looking at the top?
I mean, I see him up there. And it
Yeah,
looks
but
like
the
he's lit up,
span accident.
maybe he's muted.
Yeah, I don't know. So I think we still have to work on that a bit, but it's old business that will probably carry forward. Anyway, so I'm gonna move to new business, which is our public health forum. And I'll make it as fast as quickly as possible. In 2020, March 2024 is when we presented the very first public health forum. As you guys saw from a couple of previous outlines, we're gonna try to make it relate to a very critical time in our country's history, with it being 250 years of the Declaration of Independence, with all the uproar in the government, certain changes that a certain regime wants to make that, is troubling to most of us. It's timely that we respond to some of the what I believe, and others as well, would be severe changes. Health is a very critical component of our lives, and having a high quality of life. So I want to make sure that in terms of health, we give it that not only historical perspective in in a brief way, but have a case study of what's going on now, and then present something positive for the future. So there are 5 topics that we would gather around. The committee this year is comprised of, we started out small at first, just dealing with, the concept, the fact that CUNY's Dr. Judalise Gomez made a call, we worked together before and stated that they wanted to work with Community Board 9 because they liked the other public health forum and other presentations that we've done. So that was a positive. They have agreed to cover a number of costs, primarily, as it turns out, space. So we have confirmed in an expanded group of maybe 6 people, 7 people, including Wendy Millett, who has a youth focus, youth and mental health focus again, to visit the NAC building, which is at 106 Convent Avenue at 138th Street. There are 4 areas, 3 on the main floor, very close to each other, 2 lecture halls and 1 flex room, as well as the faculty dining room. That would be locations for us. One would be devoted to the youth forum, and then the other would be devoted to our primary clinicians and presenters. And other things that we have to work through quickly related to special features. And then the faculty dining room would start out just in the morning with a special breakfast session is what we're looking at for the youth. And then end in the evening with a plenary session with a couple other notables that we're trying to get. So that's the location, the date, Saturday, April 11th. Starting at 11 a.m. to 4. Of course, setup time would mean we'd get there earlier, like 9 o'clock as we did, before. Providing those persons with tables, to be table sponsors, to be part of, set up in the flex room. We're looking to once again have a good number of sponsors. Hopefully we can have about 28. Last 2 years ago, we did have 28. Actually, almost 30, but 28 for sure. So we're hoping to have the same. The rooms are lovely, actually, at City College. So that's date, time, and place. The topics of discussion, I hope, Monique, hopefully you can fill me in if I left out a couple of them. But the first grand topic that's a national as well as local to national, national to local vaccines, and I mentioned that before. So the study, the whole emphasis on vaccines. The second thing relates to women and maternal danger. What we are confronting now from just the standpoint of our sex, as well as the politics of all of that, what needs to happen, because it's at a critical point. The third is narrowed down to just a general topic of sexual health. And that will, I think for the most part, that's already lined up with CUNY, at least Dr. Gomez, and those at the CUNY School of Medicine have an idea of what they want to do, and they can incorporate LGBTQ as well as other aspects that are general to sexual health. The fourth is the area of youth and mental health. And on the outline, I put youth and making it through, because making it through has a particular program. And Dr. Gomez already has, we have Wendy and her team that's going to talk to Dr. Sydney Hankerson, who's a noted psychiatrist in this area and noted throughout the city. And he's connected to the CUNY School of Medicine and one of the hospitals, if not 2 of the hospitals. And that's 4. There's one other, and Victor had a contact to Niles, someone with Niles. So I think the youth will be nicely covered as it concerns troubleshooting and mental health. If there was a fifth, there's another one. There's one I thought about, pharmaceuticals, home remedies, a whole discussion around that.
The mental health part though, because we talked about how important it was, I didn't think it was necessarily restricted to you, though they're gonna break out. I thought we were gonna also have a section where it would involve adults.
Yeah, but I'm wondering that. That's absolutely correct. I'm just wondering, now I pulled out how we did it time wise before. So we'll take a look at how it could be presented again, but yes, as a matter of fact, the concern. Who I think it was Wendy that brought up bias as the whole thing of biases that people have and the stress that puts on one's life. Living from day to day as the recipient of that bias or the one perpetrating the bias. I think there's a problem either way. So yes, you're absolutely right, Monique. And there's also the idea also of at the end, a catch-all panel that can kind of not only include an update from 2024 where they talked about cannabis, what's going on, maybe that's one of the things that could be called, what's going on, or what's the latest and, what's happened since. So, some of those, we can contemplate, we can get enough of them back. With some updates and they form a clinicians or clinical panel. And maybe also ask some other questions that can wreak havoc in people's lives, even a question related to gastroenterology. How many people knew about hiatal, what's it called, hernia in the chest and that kind of, there are all kinds of things that are kind of common, but we don't talk about them, but then, there are issues that arise. So we're still formulating it, but if any of you on the committee want to, this is our next, today we had Columbia University Irving Medical Center join us with two representatives, a key one, the Vice President Sandra Harris, she's very excited about it. And we're gonna have Ryan Health with Dr. Roshana Lynch, and of course, Dr. Danielle Milano with Heritage Health. So we had our doctors on board.
Dr. Williams too, right?
Yes, but he as a speaker, so this part of the planning committee are the ones I just named. And we're, excited about some of the others that we want to get, like Dr. Uche Blackstock, Dr. Darian Sutton. And of course, Dr. Elijah D. Williams, I'm pretty sure, Sandra knows we want him, and so she's gonna talk to him, but there are others of us too on the committee who can reach out, let him know that we're excited to have him with us.
And sorry, you also mentioned the health commissioner possibly.
Oh,
The
and as a
OHMA.
special guest, yes, Dr. Alistair, maybe we could reach out to Pat Moore to help us with him, or just, first of all, get the letter out, and then we could have Pat Moore and maybe perhaps Pauline would be willing as well to reach out on our behalf to have it as a speaker. And we have to figure out for sure what it is that we want him to talk about, but maybe they would be part of a panel or maybe a presenter. So as long as they can cut. In addition, in terms of our promotion and marketing, Chinja Menagello, who did our brochure as an online brochure and QR code brochure, is willing, very willing, and excited about doing it again this year and doing save the dates for us. So I'm really excited about her because she's really just an excellent graphic designer. And so she's willing to do that. The other thing in terms of translation services, we have people in our community who not only speak English, but speak Spanish, of course. We have some of the doulas who speak various, there's several other languages. Sandra Harris at Columbia University will look into that as well because there's something they use by using the telephone where people could have access and understand what was being said. So that's gonna be utilizing the cell phone more than likely. I don't think we would need an audio AV screen. We might, but I think not. So that's covering a lot so far. We're looking at getting as many people as possible, especially as it concerns the tabling, sponsors. And, last time, I know Edwin's thought it was like 150. I think that's about right, because some people come and go. Most of the people stay pretty much toward the end. And so we're gonna shoot for a couple hundred this time. Let's see, so we have to work on food and we'll work on special guests. So we've gotten through quite a bit, but by Monday next week, we hope to have a lot more answers to presenters and speakers. And how they will be done, whether they will be just like a keynote or plenary speaker. Uh, two people on a particular topic, a panel, the different ways that we can do this, we'll try to work through. So we'll start meeting, we started actually today, meeting 12:30 to 1:30 every Monday, and in between, there'll be conversations, outreach to people. But 12:30 to 1:30, we missed you, Monique.
Yeah.
But
I'm so sorry.
anyway, and I'm gonna send it, now we're ready to expand it, cause
Okay.
initially it's kind of like you have to start out a little small or else it becomes like too unwieldy. But we welcome this committee in particular, sitting in where you can, I'll send out the Zoom link to the committee. And that's it. Any questions?
Yes, Laquita, I've had
Yes.
my hand up.
Oh, I'm
Are you
sorry.
guys, how are you? Are you guys going to do substance abuse? Because it's a major issue in our community. We can try to pretend all we want.
It is, I'm not sure, we were thinking about that, I don't know if it could go with cannabis.
Well, yeah, I mean, I think that we talked
Cause I
about.
know Monique's been talking about it, so let's
Just a
see how-
concern about self-medicating and all that, Monica, it kind of came up, so, yeah. I guess we have to figure out how that would be looked at, but, yeah.
I don't know, there's one section I just had pharmaceuticals, home remedy and drugs. I don't know, somehow it probably all. I don't know, maybe in the mental health portion, part of that could be covered also. How people look to something else but then,
Right. I mean, I think what was she, a physiologist? That
2 years ago,
Yeah, I mean,
she was good. That's-
she needs to educate the community about, it's not just weed. These kids are smoking everything. A
Yeah,
lot
the
of these,
fentanyl part has increased, I
You're right.
believe.
Yeah, absolutely.
and it affects,
Brings
it's so
down-
bad. It's so bad in the courthouse that the court officers have to walk up and down the aisles with Febreze for us to even sit in there.
Yeah, I mean, they could just have been smoking heavily and it's all on their breath and, it to me is just, it's a bit much. It's a bit much. I want to make a recommendation, again, I know I mentioned it to you before, Monique. There has been a whole section on, cannabis etiquette also. That has to be drummed in, with the businesses helping, whether people are standing outside. I got a call and I said that our cannabis committee is working on it, but the neighbors are really upset about the new business that's proposed for St. Nicholas.
Well, that's a whole other issue.
But they appreciate the fact that I think you had recommended that it be tabled, or
Yeah,
was it?
we're gonna follow up regarding that particular dispensary.
I knew you were working on it.
But in terms of the smoking, that's a whole other issue because, once again, people are supposed to smoke, I guess, in the same areas where people smoke cigarettes. And that isn't necessarily well, monitored or enforced.
No,
So-
no, people can smoke weed wherever people can smoke cigarettes, which is everywhere.
But
And
that's
you
what
know,
I'm saying,
and
that's the problem.
but I'm saying though, we need to educate our community. One of the reasons why they're smoking is because they convince themselves it does no harm, but
Well,
it
yeah,
does.
No, I agree with you in that regard. There's other things that people need to be aware of when it comes to smoking, but what Laquita was talking about is basically, I guess, policing where people smoke.
Right, but that wouldn't be the topic for the health. Right, but that wouldn't be the topic for the health.
Right, no, those are two different separate things.
Right, yeah.
Right. No, I hear what Laquita is saying, and once again, I say it's a fine line. Because you don't want to criminalize people for smoking weed.
No.
Cause that's why we're here now.
Yeah.
We can make them.
But yes,
About other people.
we wanna educate people, but not criminalize them.
Well, I didn't use that word. I didn't use the word
Yeah, but
criminal.
we also don't criminalize people for not picking up their dog poop, but we have a whole.
Exactly, that's a whole-
We shame people for not picking up their dog
That's
poop.
right.
And this last blizzard, people did pick up their dog poop because there was a bunch of shame.
Mhm.
So let's put things on the link that yell at people for smoking near building entrances.
Right, exactly.
Yeah, because I mean, you really don't want to walk through that, but I think it's more. I use the word etiquette.
Yeah.
I didn't use the word criminalize.
Yeah.
But okay, Monica was,
It's
That's
been noted,
been
and I'm
duly
so sorry,
noted.
yeah, I'm sorry I missed today.
Yeah, we just need for somebody to educate the community because right now
and maybe we're gonna
people
have her
don't
come
realize it.
Yeah, I mean, I'll reach back out to a doctor, her name is escaping me, but I'll reach back out to her.
Yeah,
Mount
she was
Sinai.
excellent. She
Yeah.
was excellent. She was good. So that's why, maybe one segment on revisiting and see which ones
Where we're up to, yeah.
we can come back.
But we need to, what is the health department saying are the top 5 health issues in this community? We need to address those. We don't need to be scattered. We need to be really focused.
You know what? She did not address them, and we did not ask her in terms of the top 5. Oh, wait a minute, Cameron is that your hand up, Cameron, or is that a legacy hand?
I think that's the cursor.
Oh, that's, okay. I know the pressing issues that we asked about. Legionnaires, the whole Legionella and accountability on that, the follow-up that we did not get from the summer cases. We want to be on record hearing about that.
Is that what
She
Mom
talked
has?
about, no, she had the top 5 things. So we
Yeah,
know.
that's what we need to talk, we need to be very targeted. We cannot be scattered. What
So
is it?
so
What are the
Legionella-
top 5 things affecting this community
Okay, got
in
it.
Right.
health?
We knew the Legionnaires thing was one part. And so she did make a big statement on that, and we asked a number of questions, and she's gonna come back with the additional documented answers. But that, we know that's the top one.
Mental health.
We did not really discuss mental health with, or hear from her on that.
From who? I thought,
Pauline.
I'm sorry,
I can tell you right now, mental health is what's driving all the crime in the city. And if you look at the stats, guess where the problem is central? It's Harlem. We can
Yeah.
try to pretend, that we've gentrified. Harlem is one of the major issues. These are not people living in communities. These are people that were born and raised here.
Mhm.
And it's
Right.
fuel. We need to deal with what is going on in this community to address the mental health issues. What's
Right.
going on in this community to address drugs? What are we doing? My guess is that probably top 5: heart disease, diabetes. I can't be far off.
Diabetes, definitely.
Absolutely. What are we doing to address this? Cuts have been happening. food stamps have been cut. We're not talking about that, but that's impacting people's decisions to buy insulin.
No, the fact is the top diseases.
Right. We need to deal with the top 5.
Not diseases, health issues.
Right. Or my guess is cancer is probably up there. Kidney
I think-
failure,
I
high
think it
blood
also-
pressure,
What was it that you said, Monica?
I think it also
kidney
depends on,
failure, high blood pressure. That all goes together. That you need like a pulmonologist to come in. Absolutely.
Chronic conditions. Camera.
Cardiologist.
yeah, I agree, Monica. I think it depends on, you know, like whether you're talking about, you know, top 5 in terms of, you know, causes of mortality, if you're talking about top 5, you know, preventable, causes of preventable death, if you're talking about top 5 most important community issues as, you know, sort of determined by like community surveys. But I think a lot of the ones that you mentioned, you know, hypertension, heart disease, you know, diabetes, cancer, HIV, sexually transmitted diseases, asthma,
Yep.
respiratory disease.
Those are all
Those are all like
big. Right.
those are all huge, and I think
Yeah.
and I think the question, and I think that's kind of where our work comes in, is determining how do you, you know, solve those issues, or how do you address those issues? Because I think, you know, a lot of those, if you're talking about hypertension, diabetes, obesity, a lot of those are, you know, obviously there's, you know, genetic components and environmental components, but, you know, what can we do as a community board to, like, you know, encourage diets that are not going to be conducive to hypertension, heart disease, diabetes, obesity. And if we're talking about asthma and respiratory diseases, then I think the question that we have is like, all right, what can we do as a community board to create environments that are not producing?
Right, but we just need to deal with that. That's a long-term problem. We need to deal with this for the health fair. My dad died from kidney failure. I know all about it. My mom died from a stroke and lung cancer.
That's right. Mm-hmm.
I know I've been at those conversations twice.
Yeah.
These are persistent problems. High blood pressure made my dad's kidneys fail, and it is still an issue in our community. So we need to pick 5 things. I think mental health, substance abuse.
I wrote down about 7 that you had, Monica.
Right. But you know, you can deal with the pulmonologist, and the cardiologist can deal with it. I think that woman up at Columbia, she's the one that did that presentation, Laquita. I think she could probably drive that. And what resources,
again.
right, and what resources are available in our community to deal with those issues. We need to keep it simple.
I think that's a good point, because we talked about an update, bringing those people back, and they did touch on the pressing topics, but we need to say it just how you've stated it. The top 5, these are.
Right.
I think that's important.
Right.
Was it Edwin? It seems like there he is. I don't know if that's him.
Yes, him.
Edwin.
Yes, Aquita.
Sorry about that.
No worries.
What do
I
you
was trying to
think?
unmute myself.
I like what Monica and Cameron, and what's your feeling on the top 5 and what was stated? And then
I think a lot of what.
top 5 depressing.
Things, I think so.
I think we pretty much have it, we could work that out, panel, almost.
Almost.
Mm-hmm. Was there something that you were trying to add, Edwin?
I think that, you know, we have the community health assessment of the Department of Health, you know, conducts, and there, you know, we can look at what are the top, you know, issues affecting the community, because they have already done that work for the community.
You said they've done it?
Yes.
Absolutely. The community health assessment looks at, it's supposed to be done every 10 years.
Yeah.
So they do look at the data and put it together in a package. So, you know, if we want to have a data-driven approach, you can look at that and see what are the top issues. What comes always to the top is, you know, cardiovascular disease, right in line with what's happening nationally and globally, diabetes, obesity. But I would say to look at the community health assessment that the DOH conducts, and then you can see what are the top, 5 issues affecting CB9.
I think the last one was 5 years ago. I think Pauline should have the most recent data. My guess is that there isn't a change. There is a proliferation of sexually transmitted diseases, both in Harlem and the Bronx.
Yes.
And it's exploding. So,
That's why
we
we
need
have
to,
the top
right,
conversation.
right. We know diabetes in our community, and not only that, but 70% of the people that died from COVID had diabetes. So we realize that that's an issue. My concern is that healthcare availability in our community is going to shrink. So how can we make sure that these people have access? People are going to lose their Medicaid because they're not going to be able to complete the paperwork and do what they need to do. That's just reality. So what are the resources? What are the issues? And how can we deal with this?
Excellent, Monica.
Maybe we need to have a
I mean,
legal
we've had-
perspective to
Yeah,
address it
yeah.
in a small way,
Mhm.
maybe. I don't wanna-
Yeah, yeah. I mean, we can't be, we don't have to be scattered. We can be very focused. We have the resources, pulmonologists, cardiologists, hematologists. We can get the people in here to deal with it.
Yeah.
I don't know, who deals with diabetes?
Remember we did
Pulmonologist?
the
Yeah,
budget assessment, and I was insisting on that center on 126th Street or 127th could still be used. They want to tear it down, but we need specialists to come in here. There's even with Ryan Health coming, and we have Heritage, we still need another center, other doctors.
no, absolutely. But I mean, I talked to Victor, I told him, I said, those, Ryan Health has opened up a center there, and
Yeah,
the
they
other one
presented to
is open up. We need to try to see what we can do. That means working with Espaillat's office to make sure that they stay open, because our community needs that.
Right, exactly. And that's why 127th Street, that could be a focus to, we had the one, the health center on
The health
120
clinic,
it's
I mean-
6 and 127, close to Old Broadway.
Right, yeah,
Yeah.
you're right, they should have closed.
Jordan?
I just had a question, I think for Edwin. I know there's a community health assessment that does risk, like causes of death, but I guess, are there any studies that show poverty as a cause of death? Because obviously diabetes could be a cause of death, but it wouldn't have been a cause of death if you hadn't been rationing your insulin. This is this is a thing that happens. Yes, if you had taken your meds for your mental health condition, you wouldn't have, taken your own life. But if you couldn't afford those meds, and so I'm just wondering if there are statistics that kind of take that bit into account, because if 30% of people are dying because they cannot afford or access their healthcare, that's very different than, oh, we have some people dying of cardiovascular issues, some people have diabetes, some people have liver disease, some people have mental health issues, some people who are self-medicating their mental health issues with alcohol end up dying of liver disease. But
Poverty is the big.
is there a study in this area
I
that
think there
attempts to
is.
quantify?
Kaiser did a study.
Kaiser?
So what you're describing is called the social determinants of health.
Right.
Yeah,
And that is that is an area of focus within, medicine and public health. And it takes into consideration those factors that you are describing, which is, those factors that are beyond just the biological, right? Those factors that, as we can say, are man-made. Factors like your housing, poverty. These are things that are policy driven. So the social determinants of health, you do have, tools that are validated that have been used for quite some time now.
Isn't a community health assessments done by VOHMH, don't they take into consideration as a proxy income? I'm sure
So
they look at that.
they do look at that, and these community health assessment are conducted using validated tools. Sort of like just like when you diagnose a patient, but this is diagnosing the community. And they are, well-defined metrics that one has to use to try to remove, your biases and follow the data. One of the, measurements that they look is ICD-10 codes, right? This is a code that your provider puts in when you go to see them. And they look at all that information to come up with these conclusion and these health assessment that are not only done for our community, but done for all communities
Yeah, every
in the
community.
state and in the country.
Mhm. But the reality is most of it's genetic, right? I mean, we have to deal with that.
I don't think that's true, actually.
Yeah.
Well, I mean, I was part of a study because my dad died of kidney failure. I was part of a study that was at Wake Forest Medical Center in North Carolina, part of Bowman Gray Medical School. And they were studying the genetics of why men pass on high blood pressure to their sons, but they do not pass it on to their daughters. And it was fascinating.
Yeah.
I was in another study because my family has a long history of heart failure. I was part of that study, and it is genetics. And that's why the doctor was like, you've got to monitor your heart. I mean, I'm lucky. I don't know what the genetics of it was, but I did participate in the study. And I have great doctors. So we have to deal with that component.
Absolutely, and there definitely is a genetic component to all of these
Absolutely.
diseases. But I think that there's, also like a very huge societal component of like,
No, of
whether
course,
you're,
of course.
able to get treatment for the disease or even testing.
Absolutely. Or whether you will go. The reality is Black men do
Absolutely.
not go to the doctor, even when they have access and insurance. That's why there's a lot of groups working on that. My dad had access and insurance.
So this comes to the question of nature versus nurture, right?
Right.
And in public health, we say that, your genetics loads, I'm going to be, graphic here, loads the gun, but then your environment pulls the trigger.
Absolutely.
So it's not, 100% one. There's many factors. When a patient comes to me in the clinic and asks me, why did I develop diabetes? I cannot tell you why you developed diabetes. I can tell you the risk factors that put you in that category. But if somebody tell you got diabetes because of this sole factor, they're lying to you.
There's no sole factor, but we need to educate our community. Just like
Absolutely.
if you have a history, as my doctor told me, my family has a history of heart failure. I have to be careful about everything that I do.
That plays into the equation that we look into.
Absolutely.
Yeah.
But we need to educate our community as to what they can do to avoid that.
Absolutely. Yeah.
That's it.
Education is a foundation. Yeah.
Absolutely.
I also just want to, I know I'm home, but I wanted to give a gentle time check to folks because I know Ashley got to
We've
get
done
on there.
that, we've done that, we're just letting, this is the last part of it.
Bet.
So Monica,
Okay.
thank you so much for those comments. And they're very valuable and we're gonna, they'll definitely be incorporated into the public health forum and maybe we need even that committee, one of the committees to explore it some more, dig into it. Edwin and Cameron, thank you both so much for the clinical insight. And let's see what I think we make a motion. That's it. So good meeting. Can we have a motion to,
I move for us to conclude this meeting at 8:34. Would somebody like to second?
Don't turn recording off yet, Joy.
Second, I'm just looking at the link.
All right.
Seconded.
Thank you.
Did we ever adopt the?
Yeah, I didn't know.
Oh, for the record,
Motion to adopt the agenda.
thank you so much.
Thank you, because I know you said it when I came in.
Yeah, I
know
did
it
it,
happened.
and
Thank
I
you,
kept
Heather.
thinking of it, but the conversation, okay, so,
So,
And-
motions were made?
yeah, please make a motion, Heather did actually.
Thank you, Heather.
Seconded.
And Jordan has seconded the adoption of the agenda.
Agenda and minutes. And minutes with, whatever corrections you may see. Okay,
Good.
thank you. All those in favor? Yeah, because we have to vote on there. Aye, okay.
Wendy didn't have anything to add, I assume.
She may have even stepped away. I know she
Okay.
talked about earlier.
Okay.
Wendy, okay, well, we've concluded, but we'll see you next week, Wendy.
I'm good. I listen. See you next week.
Okay,
All right.
all right,
Good night.
thanks, everybody.
And I did just
Good
I
meeting.
just wrote a resolution for the New York Health Act. So check your emails. Hopefully we can get a vote done
Just
by.
started, but check our emails.
Maybe pulled one, which is great. I'd say we never reinvent the wheel, you know.
That's right, if you got, yeah, probably, yeah.
I'll send it tonight. I haven't
And
sent
if
it.
you guys, if you
Oh,
guys
yes.
pass it, please send it to me and I'll bring it to the state legislator next Tuesday and
Sounds
present it.
Oh, fantastic.
Oh, yeah.
Yeah, if it gets past the committee first, so that's why once Cameron does, he hasn't sent it yet, he said. But once, we'll do it with a vote where you have to say yes. And well, your name, yes or no, or you can make amendments, suggest amendments. Okay, and then when the committee votes, then we could send it. Cause executive is next Thursday, and then the following week is the general board. Okay,
Have a
thanks,
good night,
Edwin.
y'all.
Good
I
night,
don't think
everyone.
we have that, is it recorded, what Edwin just said? We still have recording on, right?
Yeah, recording's still
Oh,
on.
good, good.
All right.
Okay.
Oh, that meeting he said, or with the.
To the state, who are you gonna present
Oh,
it
you mean
to?
with Gustavo Rivera?
Oh, it was gone again.
So, it's lobby day. So we
Oh,
will
that's
be
right.
going to the state. And you know how
Right.
it goes. You go to all the legislators that are there and you lobby
Right.
for, the issues that are present in the community. If this
Right.
is passed, I can bring it up and say, look, Community Board 9,
Yeah.
they are in favor of this. Because this
And
is
it's gonna be
the
voted
items
on.
that that they're putting forward.
Sounds great.
Okey-dokey.
Thank you, Edwin. I'll talk to you soon.
Sounds good.
it's
Take care,
8
all.
Okay, so it's 8:34. Let me make sure. 8:34. Or 8:35, but the call to adjourn was at 8:34, but we'll have to actually adjourn at 8:35. Okay?
Sounds like a plan.
Yeah, he and Monica jumped on the other side.
Toodles.
And
Stop recording.
yes, we can stop now.